thanks everybody for joining us today. So I guess the plan today is for us to present the findings from a recent systematic review that Giuliano and I and colleagues have conducted, looking at the impact of basically lockdown and control measures on women and child's health, with a focus on low and lower middle income countries. What I'll do first is just give you a bit of a background and also I guess let you know how this fits in with this broader UK RI study that we're a small part of. Then we'll look at the methods that we used to go through our systematic review. We'll present some basic results. We'll try, we can't cover every single paper that we came across in the systematic review, but we will give you a flavour of some of the key mechanisms that come out of the review and some of the evidence before we can then conclude with some discussion points. So what is the background? Well, part of this, I'm describing some issues that pretty much all of us who've experienced any challenges with COVID will be more than fully aware of. We know that that there's been a long history of using these kinds of lockdown or social distancing restrictions to address infectious diseases. So when we're thinking about COVID, a lot of these policies have been used to address issues in the recent past, such as the recent Ebola pandemic. So there's already an established literature, and from our own experience, we know that lockdowns come with potentially unintended consequences or known potentially harmful effects that are kind of posed as collateral damage. So there's often this talk within policy-making circles of making trade-offs. In particular, and I think this is what we're particularly interested in, is that we know that despite these kind of lockdown and control measures addressing one health issue, there can be consequences for other health issues, particularly as some of us may have experienced in the UK and other parts of the world around mental health, access to other health services, and impacts on our livelihoods, which also have further implications for health. Alongside this, we saw, and this is really supporting the call for the need for this kind of research, a massive outpouring of academic commentary and social commentary highlighting how the implementation of these measures in low-income settings would be particularly damaging, and particularly damaging for vulnerable populations, i.e. children, and also that the impact is often very gendered. And again, this is something that we've also seen in the global north. So our study, this systematic review, is very much kind of a background study to say, well, what is the current state of the evidence, the concrete evidence on the impacts of these measures, and drawing on not just the COVID, the recent experience with COVID, but also recent other infectious disease outbreaks. So just a small amount of background on this broader UKRI project. And again, I can see lots of colleagues that have joined us. This is a multi-country study being conducted in Ghana, Tanzania, Uganda, and Zimbabwe to, as you can see here, really understand the impact of these measures on women's and child health. So our study is really, our systematic review is really providing a kind of broad background to this project as a kind of, as I've said, a review of the current state of the evidence. Okay, so I'll hand over to Giuliano now to discuss the methods.
Yeah, the idea about this systematic review really came about when we started the project, and as in any good project should do, we started reviewing the literature and what is already known about lockdown measures and the effects of lockdown measures on vulnerable populations. We quickly realized that there was quite a lot in terms of opinion pieces, in terms of commentaries, but very little evidence. So we started looking back to other epidemics. We have been here before. It's not the first time that lockdown measures have been imposed on people, and it's not the first time that people, as scholars, have raised the flag on the effects, deleterious effects of these lockdown measures on vulnerable populations. So we looked back, we started looking back at the papers referring to the Ebola epidemic and MERS and so on and so forth. And we came up with this idea of looking back to all the papers and all the evidence had been produced from past epidemics, not only COVID epidemic. We started doing our searches in 2020, so not much had been published at that point, so there was a need to look back at other experiences. We searched databases. We used the PRISMA guidelines to inform our choices. We very quickly realized there were quite a few very interesting frameworks. I would like to highlight this framework here by Glover et al. On the repercussions of lockdown measures on inequalities and on the vulnerable. So we started using these frameworks, adapting these frameworks to inform our searches. So we looked for evidence dating back the year 2000, trying to cover all the most recent epidemics. We looked for any kind of quantitative, qualitative, mixed method evidence. The inclusion and exclusion criteria were very much ones of trying to bring in primary data or maybe papers investigating and interrogating with carrying out different analysis of primary data. So we really wanted to see what the landscape of the evidence was on that. There was an issue on what search terms we may use to identify our outcome of interest, but also to identify lockdowns. Lockdowns is a relatively recent term and terminology that has become mainstream in this COVID epidemic. So we explored different ways of calling the same things, from non-pharmaceutical interventions to containment policies to specific closures and prohibitions and restrictions. And with these search terms, we searched the 7 most relevant databases. We focused on low-income countries and lower middle-income countries. You know, the terminology has changed over the years. These days, there are very few low-income countries, but a significant portion of lower middle-income countries can still be considered as, low-income according to the World Bank and IMF definitions. This is the PRISMA flowchart identifying all the relevant phases of identification, screening, eligibility, and inclusion phases of a systematic review. These are the phases described by the PRISMA guidelines. So initially, we identified 880 plus 16 other publications from other sources using snowballing techniques. We started screening the titles. 2 people did it independently, and then we arrived at 63 papers to be assessed for eligibility against our inclusion and exclusion criteria. The main reason for excluding these papers were that maybe they were not presenting original evidence, they were not focusing specifically on mother and child health, or they were not on lower middle income countries. We only found papers and evidence from 2 epidemics, really, despite having looked back 20 years. Evidence from the most recent COVID epidemic and evidence from Ebola. Most of the papers used quantitative data, different techniques from analysis of surveillance data, economic evaluation, mixed methods studies, a lot of modeling as well, and a lot of studies using surveys. Only 2 qualitative interview studies met our inclusion and exclusion criteria, And there was also an interesting time series analysis study from Equatorial Guinea. So in total, 46 studies we review. Where are these studies from? Next, please. Yeah, they are mostly from Africa, sub-Saharan, West Africa, sub-Saharan Africa, understandably the areas where the Ebola epidemic, 2014-2016 epidemic hit the hardest, but also a lot of interesting studies coming from East Africa, and especially from Uganda and Zambia. And then there were a cluster of studies from India, Pakistan, and Bangladesh. And then there were the more modeling kind of macro studies looking specifically at lower middle income countries without really going into the details of any specific country. So yes, these are the origins of our studies. And I think Kevin will talk a little bit on the main results of our studies.
What I'm going to do is just present a flavour of some of the evidence that we uncovered in our search. Obviously, I can't go through each of the 46 papers, and because this was very much a mixed methods review, the aim of this systematic review wasn't to, in the end, produce a kind of meta-analysis. So it's more descriptive and looking at the kind of evidence that was emerging, and also identifying all the different types of mechanisms that through which lockdown and associated control measures can impact on a range of health outcomes. So this first kind of theme, really focusing on the impact on utilisation of mother and child services. You can see here some evidence from a modelling study conducted in Guinea, Liberia and Sierra Leone, projecting a massive decrease in the number of children vaccinated for measles. Again, we see in Nepal a lot of evidence around a massive reduction in use of maternal services, and in particular the proportion of births, live births, that were in a formal institution. So that obviously has a lot of additional negative consequences on maternal health. And again, similar findings from a study conducted in Ebola around a massive decrease in the number of institutional births, even as you can see here, that case numbers are quite low. And this kind of raised questions that Giuliano will discuss a bit more around, what's driving these decreases in institutional births. Is this about supply and services, being suspended, or is this about concerns around, from mothers wanting to access these services if they're still there? So that's something that we'll discuss a bit later on. But there's definitely probably one of the, I think out of the main themes, this was one of the themes that had been focused on the most in literature. I think almost about a quarter of the papers that we found were focusing on issues around maternal health and access to safe births, and around immunisation and vaccination programs for young children. That's one kind of key strand. Sorry. The second strand of literature actually focuses on trying to quantify the number of deaths that either have occurred from primary evidence or through various modelling scenarios. Again, we can discuss this a bit later on. There seems to be in this strand of research more of a reliance on modelling, and these kind of quantitative exercises come out with some quite disturbing results. In terms of primary data, a prospective observational study found that in Nepal, neonatal mortality rate increased from 13 per 1,000 live births to 40 per live birth. So that's quite a startling increase. And then looking at the modelling exercises, there was one modelling exercise conducted using data from 54 sub-Saharan African countries. This was essentially almost like a cost-benefit analysis, looking at, for a range of different scenarios, what the impact of the suspension of an immunisation programme would have, and comparing that to excess deaths attributable to COVID. And you can see here the conclusions are quite interesting for the debate around whether countries should lock down in these settings. You know, for one excess COVID death attributable to one excess COVID death attributable to continuing vaccination, 84 deaths could be avoided by actually sustaining these immunisation programs. So, you know, this evidence is really speaking to the trade-offs that policymakers are having to make around you know, the impacts of doing something compared to doing nothing. And finally, again, you know, that there's so further modelling data from Sub-Saharan Africa is looking at disruption to HIV services, so disruption to testing, access to treatment, provision of drugs, supply chains, and mother-to-child transmission. And again, is predicting a significant increased number of HIV-related deaths. In terms of mental health, again, unsurprisingly, you know, we have a range of emerging evidence, often through the conduct of online surveys using fairly standardized mental health scales or alternative questions. And again, we see increases in mental health problems, anxiety, depression, stress. Often these surveys that we've drawn upon include data for both men and women, and what we're kind of seeing across these studies is that women are definitely reporting you know, more serious, significant mental health concerns than men. There's also a strand of literature that looks at diet and nutrition and also sleeping patterns. Again, you know, there is this, I guess, links a bit to the issues around social vulnerability that we'll discuss later. But there are concerns raised around, you know, increasing malnutrition, changes in feeding patterns, lack of access to food, and in this case, milk formula. But on the other hand, I guess that this is where we begin to see some differentiation in the impact of these measures on different classes. You know, some kind of inequalities. So for some people, accessing food is a problem. For other people, actually, you know, eating more unhealthy food or snacking more often that becomes a problem. We also have some emerging evidence on the impact on physical activity. And again, you know, these are what you would kind of expect based on our own experiences of lockdown measures, that, you know, physical activity and intensity of physical activity is decreasing as well. There's also an important strand that has begun to document increases in gender-based violence during lockdowns. So evidence from a randomized control trial that was actually on something completely different, that was utilized for a COVID study, showed that for women that had reported previously experiencing different types of abuse and violence, that, you know, a significant proportion of women experienced these worsening throughout lockdown. So you're looking at, you know, over half, 50% of women who'd previously experienced sexual violence were reporting that worsening during lockdown. And again, this is kind of supported with evidence from Tunisia. This is an online questionnaire. And again, you can see here that violence against women significantly increased during lockdown. And this survey also found that women that had previously experienced domestic violence and abuse were also more likely to experience an increased risk of that during lockdown. And finally, sorry, the slide's a tiny bit messy, but again, we're seeing lots of emerging evidence, some from qualitative work, some from modelling, that again is emphasising a big impact on social vulnerability, on food security. You can see here a particular case study on the fishing zone, looking at disruption to markets and value chains. And this is all creating feedback loops into the sorts of measures that we discussed earlier around diet, access to healthcare, affordability of healthcare. And, for us as, economists and political economists, we're really also interested in, the causes of poor health. So this increasing social vulnerability is helping us understand the broader social determinants of the impacts of lockdown and associated measures.
There were quite a few interesting discussion points coming up from from the evidence, but in the interest of time, we try to summarize into 6 big areas. First of all, we were surprised by the evidence that is available, but also the fact that this evidence seems to come only from the 2 most recent epidemics. What happened to the impact of lockdown measures in the previous epidemics is still not known, probably because this terminology or this interest around the lockdown measures is a fairly recent one, and extensive lockdown measures have only been implemented in the 2 most recent epidemics. There are some methodological concerns. We don't really know what the gold standard of evidence should be about impacts of lockdown measures. There were very few large-scale surveys, possibly because of the timing of our review. And quite a lot of studies relied on online surveys that had very little generalizability. It was unclear, this is a big point, it was unclear what specific lockdown measures was determining what. Very often this lockdown terminology is very vague, so it's very difficult to establish a link, a causal link between one specific aspect of the lockdown policies and an impact. The initial findings suggest that women and children, vulnerable populations, are disproportionately affected. This seems to be quite clear, emerging quite clearly, that lockdown measures disproportionately affect the vulnerables, the ones that don't really have too much slack on how to go about their livelihoods and how to go about provision of healthcare services and so on and so forth. Suspension of services seems to be the key driver of impact here, more than all the others. So the fact that healthcare services are suspended during lockdown measures is clearly the main channel through which lockdowns seem to impact the vulnerables. It's not clear here whether this is a demand side or a supply side effect. Is it that people utilize less services because some of these services are shut down, or is it because patients and consumers refuse to go to healthcare centers or hospitals for fear of infections? This is not clear from the evidence we collect, and this matters because the policy options to mitigate these effects will have to focus on either the demand or supply side interventions, or a little bit of both. There is, and finally, the big reflection that I would like to bring to the discussion is on the opportunity to implement these policies. Obviously, these policies are important during raging epidemics to contain the epidemics, but in those countries where the epidemics don't really take hold, or their impact is not as badly felt as here in Europe, the balance of the advantages and disadvantages of imposing lockdown measures need to be considered, because some people go under during these lockdown measures and happen to be the vulnerable ones. So in those instances where the epidemics are not really felt that much, as in many countries in Africa, we have to interrogate ourselves and governments have to interrogate themselves on the opportunity of bringing on these very stringent and strict lockdown measures. The effects of these measures are still very hazy and not assessed properly, especially for the vulnerable populations. We conducted this systematic review as part of a wider study that is being conducted in Ghana, Tanzania, Uganda, and Uganda on the impact of these lockdown measures. We identified 46 papers presenting original evidence, quantitative, qualitative evidence, mostly from sub-Saharan Africa, but also from South Asia, using survey data, evidence, modeling, ecological studies, interviews, evidence. We identified 5 big areas of impact that seem to be emerging from the literature. Utilization of services and impact on utilization of services, it seems to be the #1 impact, in some cases leading to loss of lives or estimated loss of lives, mental health impacts, changes in behavior patterns, domestic violence, and increase in social vulnerability and reduced livelihoods. The link between what aspects of lockdown measures and specific impacts is still not clear and will need to be understood better. But it seems clear that there is a disproportionate burden coming from these measures imposed on vulnerable populations, on children and women in particular. And the benefits of containing epidemics through lockdown measures will need to be weighed against this understanding that during those measures, the ones that seem to pay the highest price are, as usual, the vulnerable ones, children and women.